Hey, thank you all for joining us again. This session is 1.5 hours. It's about an hour for presentations and then up to half an hour for questions. If you have a question, please do put it in the chat box, and this will be monitored by Sean and myself, and we will ask quiz questions to the speakers at the end. So today we have 3 speakers. I will be passing on Jayne initially to introduce her first presentation, but I'd just like to introduce all speakers first. So Jayne is a diabetes specialist podiatrist at the University Hospital of Birmingham and a senior lecturer on the master's courses in diabetes care and peripheral vascular disease at Birmingham City University, as well as being our very own Diabetes UK clinical champion and NICE committee member. She has worked in the field of foot disease for the majority of her career, and she's passionate about the unique role of podiatrists in the multidisciplinary team, contributing to improving patient care and outcomes. She'll be presenting on Act Now, an easy-to-use resource for healthcare professionals and people with diabetes, enabling individuals to recognise the warning signs of foot complications and to address potential delays in accessing specialist treatment. We're also joined by Christian. Thank you. Christian Pankhurst is a clinical specialist orthotist in Guy's and St Thomas and King's College Hospital. He is currently co-chair of the London Clinical Network for Foot Care and sits on the panel for FD UK. Christian will explore the link between diabetes and the lower limb, discussing why identification of risk is so important at foot screenings, and then he'll explore what services and pathways are available at different levels of risk. And then we'll also be joined by Professor Michael Edmonds, who works as a diabetologist at the Multidisciplinary Foot Team Clinic at King's College Hospital, which he jointly founded in 1881. He's going to discuss how foot problems develop and how to treat them. And he will also point out how Act Now can highlight limb-threatening situations and is an important part of the ZAP, that's Zero All Preventable Amputations campaign, by the Foot in Diabetes UK. So thank you all so much for joining us. And without further ado, I'm going to hand over to Jayne to start her presentation. Thank you, Jayne.
Thank you, Louise, and thank you for that very kind introduction. I will just share my screen with you all. Just find it. There we go. You should have that on your screen now. Can you see that, Louise?
That's great. Thank you, Jayne.
Yep, lovely. Thank you. Thank you very much. Thank you, Diabetes UK. Thank you very much, Louise, for that introduction, and welcome everyone to this webinar. I'm going to present to you now the work that we've been doing about zeroing all preventable amputations, and particularly around this initiative called Act Now, which you may or may not have heard of. So why are we worried? Why do we have, why are we here today? Why are we on this call? We know that time is tissue. We hear this time and time again. We know that the foot in diabetes has a large mortality rate. We know that people with diabetes fear amputation more than death, and that's supported by research that's come out of the States by Wukich and his team, who looked at a cohort of people with diabetes and asked them about their fear of complications, and amputation came out higher than death, end-stage renal failure and blindness. And work by my colleague on this call, Professor Mike Edmonds down in King's, and you can see from this photograph on the right-hand side of this slide, shows you that people can have an intact foot at the beginning of the week, and by the end of the week, they can have a foot that requires surgical intervention and hospital admission, and unfortunately for some people, amputation. And we know that people, when they have an amputation, whether that's a minor or a major amputation, that kind of starts their mortality clock ticking. 50% of people who have a below-knee amputation will be dead within 2 years of that amputation. 56% of people with a foot ulceration will be dead within 5 years of that ulceration. So it's imperative that we can get to these people early. We give them the power and the tools to detect those foot problems, and we give them the knowledge of where to go to get specialist advice and information that may be the thing that saves their limb, but ultimately also saves their life. So I've alluded to this issue around mortality and the importance of foot care for people living with diabetes. 7,000 people in the UK undergo amputations annually. That's around 300 people per day that have a part of a toe, a foot, or a leg amputated. Foot problems not only have a huge impact in terms of medical intervention, but they also have a huge impact in terms of quality of life. People live with pain, they live with mobility issues. Many people who have amputations are depressed. Their relationships break down, their ability to work breaks down, they become homeless, they undergo divorce, they lose their jobs, they lose their livelihoods. And patient survival after major amputation as a result of diabetes, as I've already said, and is clearly demonstrated on this chart, it can be severely reduced. So the route to amputation is multifactorial, and the problem with it being multifactorial is there isn't just a one size fits all fix. People can have comorbidity, they can have minor trauma, they can have poor healing, they can have had a previous ulceration. The huge impact factor is infection. That is contributed to with poor circulation, and people can have problems accessing treatment. They don't know where to go. Services have been redeployed or repurposed, especially since COVID. So there isn't a one size fits all. There isn't a magic bullet that we can say to people with diabetes, well, if you do this, you will reduce the risk of having an ulceration, you'll reduce the risk of having a problem, and you'll reduce the risk of an amputation. So with another group within which I sit, called the IDEAL group, and IDEAL is the Insights for Diabetes Excellence, Access and Learning. And they're an independent multidisciplinary team of experts who have an outlook to improve diabetes care across the UK. And they put forward a series of recommendations in the late 2019 and into 2020 to improve foot care and education for people with diabetes in order to reduce the increasing number of major amputations. And the IDEAL group believe that delays result in poor outcomes, and this is further supported by some of the work that Professor Edmonds and Christian and I are doing with FD UK and the ZAP Amputations group. And that these can be prevented, these poor outcomes can be prevented by earlier intervention. And the IDEAL group believe if its recommendations are followed, that there could be a 50% reduction in people with diabetes needing major amputations within 5 years. So how are we going to do that? Well, the acronym ACT NOW was devised with the direct input from a person with diabetes and this multi-professional team of experts within the IDEAL group to help to recognise those warning signs that might lead to amputation. And if any of those warning signs are identified, this should activate and empower the person with diabetes, their carer, or a healthcare professional to seek urgent referral to a specialist centre or to specialist care from multidisciplinary foot care teams. And there should be clarity of referral pathways between primary care and secondary care facilities or primary care to primary care multidisciplinary teams to promote rapid access and to facilitate the referral of feet at risk of ulceration and or amputation. So you can see on the left-hand side, this acronym, we've got it in the infographic at the top, and we have this acronym. A is for accident, C is for change, T is for temperature, N is for new pain, O is for oozing, and W is for wound. So it looks like this. You can have it as a checklist, and that's something that you can download from the IDEAL website, and you can put that in the patient notes. You can give that to the patient. The patient can download it themselves and check things off. Their carer can do it. That means when they're talking to a GP, they can say, oh, well, I've gone through this now acronym and I've got these various things. And it kind of gives a bit of information and a bit of background knowledge to the person that you're being referred to. So A, recent history of accident or trauma. C, any new swelling, redness or change in shape of the foot. That could also be changing colour. So redness might not be completely reliable. So sometimes we say just changing colour. So it may be darker, it may be lighter, there may be redness, there may be pallor. And those sorts of things might be helpful sort of trigger words for people, particularly where people have a different skin tone, so that redness isn't quite so reliable. T, any change in temperature. Temperature changes could reflect infection or Charcot if it's warmer, or if it's colder, it might give you an indication that there might be some vascular or circulatory problem going on in that foot. And is there any new pain? Is the pain localized or generalized through the foot? Does it radiate? Does it spread? Is it localized just to the foot? Does it move into the leg? What's the pain like? How often does it happen? Those sorts of trigger questions are helpful. O, is there any exudate or oozing? And again, what colour is it? What texture is it? You know, is it clear and watery? Is it thick and spotty? Does it look like custard? Does it have any smell? You know, these are all sort of unpleasant kind of ideas, but again, can be useful trigger points, particularly for people where we're thinking about infection. And for W, is there any information that people can give us about the wound? Can they tell us the size of the wound? Can they measure it? Can they give an idea of the shape and the position of the wound? That again can sometimes help people to have a bit more of an idea around what they're looking at. And what we want them to do is not only work through that acronym and identify those sort of trigger points, but we also want them to have this kind of empowerment to do something. If they're going to reduce delays, they need to do something about that. So they need to act now. Don't delay, see somebody. And the somebody might be a specialist podiatrist like me. It might be their hospital consultant like Professor Edmonds if they already see a hospital consultant. It might be their GP. It might be a walk-in centre. It might be community podiatry. It might be their private podiatrist. It might be their friend who is a specialist nurse. It might be somebody who has some knowledge who can work through the acronym and go, yeah, that's a problem. We need to get somebody specialist to see that. And you can see on the screen now the same information presented in the different skin tones that we've had it produced in. So we have a Black African Caribbean skin tone at the top on the left-hand side. We have a sort of Asian, Indian, Chinese, Japanese kind of skin tone at the bottom on the left-hand side, and then we have the Caucasian skin tone on the right-hand side. They're not all-inclusive. Sometimes people say, well, that doesn't accurately represent my skin tone, but it does give people a bit of an idea of the sort of skin tone variants that we can see for some of these issues. And I think it's worthwhile saying that, you know, we can't, as a small organisation of ACNO, we can't produce the multiple variances of skin tone, but you know, we would signpost people to the infographic that as near represents their own skin tone as possible. And this is the back of the card. So we've had it produced as a little credit card. And this is the back of the card that we currently have. There's an area in the middle, a bit like the contact card that you might have on a bank card, where you could sign your name, but in there you could write a telephone number, or you could write a contact person's name. So for me, it might be contact Jayne Robbie at, and it might have my email address, or it might have my clinic telephone number, the hotline number. The QR code at the top takes the person straight to some education that's on the Ideal Diabetes website. So that takes you straight to the information and education package that we have on there for people with diabetes to just work through, and again just gives a little bit of more background to the whole Act Now idea and what people are looking for. The The contact details underneath the signature line, they have the Ideal Diabetes Twitter handle, and they have the Ideal Diabetes website. And then we have this disclaimer at the bottom that if you are not able to see someone in the multidisciplinary foot care team at your local podiatry department or GP, that they should signpost themselves to secondary care and to A&E or an emergency department to again try and get on top of if there is any infection there. So I got some funding from a pharmaceutical grant and was able to pilot Act Now in a few centres in the UK. So we sent some of the cards to the Isle of Lewis in Scotland, to a podiatry department. In Warwick, we had a diabetes foot nurse specialist who works in secondary care. In South East London, Merton Podiatry Service and community nurses have piloted it. Birmingham Community Podiatry, and then in Shrewsbury, we had a diabetes educator, and we've had the podiatry department in the hospital trust, who've all had packages of the Act Now cards funded by the pharmaceutical grant and have given them out to patients and in education facilities. And these are some of the early findings that we've had. And quite interestingly, 100% of the people that they've given the Act Now cards to have been white British. And we can see that the age range here, we have a sort of middle-aged range, ranging from that sort of 51 to around the sort of mid-70s age, predominantly for all of the centres, whether that's the primary care or secondary care centres, and predominantly to the male population. And again, that kind of reflects the kind of patients that we would see. We see quite a lot of men with foot problems, and for these men with foot problems, often they have poor outcomes because they might have a little bit of a lack of engagement with their health. They might have issues around being able to get time off work. They may feel that they don't want to be a burden to either their families or to their healthcare providers, and so sometimes they are late in presenting. And Act Now is a way of helping them to access services in a more timely manner. And this is some of the feedback that we've had. On the positive, people have found it quite helpful. It's handy to put in their wallet. It was good for them to have a contact number written on the back to hand. The pictures made sense to them. It was something that they could share with their family. They liked the articles that the QR code linked to. They liked the idea that there was a different skin tone choice. On the negative side, some of them found the credit card was a bit small. Some of the writing was a bit small for them to be able to read. It was hard for them to read, and I would agree with that. If you're having some vision disturbances as a result of normal aging or as a result of diabetes, sometimes the print can be a bit small. Some people felt that the skin tone wasn't reflective of real skin tones, and we've taken that on board. Some people felt that the information was a bit overloaded on the card. But generally, I think the feedback from patients and the feedback from healthcare professionals who've used them, who've handed them out, has actually been positive. And people have found that it's been a useful way to bring into a conversation about what are those warning signs. Because I know in my practice, I often say to people, well, if you have a problem, give me a call. But I don't always tell them what those problems are. And I think that's where the Act Now acronym and the call to arms is a very powerful message. So the adoption of the Act Now checklist and the Act Now infographic credit card enables vulnerable individuals to recognise those warning signs of something that might be potentially limb-threatening and ultimately maybe life-threatening, and gives them empowerment to seek specialist help in a timely manner. We're pleased that Act Now has been created collaboratively. It's a one-size-fits-all tool for foot problem recognition. It can be used across the board by all kinds of populations, and is aimed specifically at reducing those delays to access specialist care and empowering people to seek early referral. So it can be used by everyone with diabetes, whether they're inpatients or outpatients. It can be used in nursing and residential homes. It can be used by community nurses, mental health teams, pharmacists, prisons. Everyone can Act Now. And the great thing about the infographic that you can see here on this slide is that, if people don't speak English as their first language, if they've come here as a result of some of the conflicts around the world, if people maybe have some learning difficulties, if they have early signs of dementia, if they aren't able to read English, if they don't have any understanding, the pictures are very self-explanatory. Hopefully they're very clear and explicit. And the acronym is very clear. It's very simple in its sort of message. Accident, change, temperature, new pain, oozing or wound. Any of those, seek early intervention. So just in conclusion, the Act Now Toolkit and Infographic is a practical, low-cost, innovative approach to reduce healthcare inequalities for vulnerable people. It can promote early access to care and reduces delays in accessing specialist foot services. If it's put into practice, we believe that there could be a 50% reduction in major amputations for people with diabetes within 5 years. It's been designed to be simple and practical to use. It doesn't need additional training. There's no license to use it. People can download it and use it straight away. It can be used by anyone, regardless of type of diabetes, education, language, or culture. Adopting and using Act Now has the potential to have a profound impact to help people with diabetes have timely assessment and specialist referral as they require it. And we can all act now to save feet. So this QR code, which I'm happy to share these slides with you via Diabetes UK if they're helpful. This QR code takes you straight to the Act Now website, where you can download the infographic and you can download the checklist free of charge for your use, or for people that you treat, or for your family and friends to use. And these are just some references. So if you want any more information about where Act Now has come from and what the provenance of it is, then the references, the Robbie and Edmonds references with Christian also included, are here for you to use, all backed up by NICE guidance, NG19. And then the couple of papers at the bottom are just interesting papers, really. One, probably quite a lot of you will be familiar with, from Marion Kerr and her team, published in 2019 about health economics. And then there's a paper that has been published just this month. It was published in Diabetes Medicine by Hex and his team in York, which talks about the direct and indirect costs of diabetes particularly, and Act Now hopefully will be able to contribute in reducing those costs by getting people seen in a timely manner. So thank you very much. That's my whiz through Act Now, and without holding you up, I'm going to stop sharing my screen and will share with allow you to share now with my colleague Christian, who's going to do the next part of this presentation with you. It's all yours, Christian.
Fantastic. So thank you ever so much, Jayne. That was a very, very interesting presentation, which was a very good introduction to the warning signs of foot complications, and just the incredible and innovative work that yourself and the Ideal team have done, and as well as the Act Now initiative. Now, hopefully everyone can see my screen for the presentation. Now, let me come through. So in this presentation, I'm wanting to talk about the determination of the risk of foot complications in the person with diabetes and the care that they should expect. And as Louise kindly introduced, within this talk, we'll briefly cover the link between diabetes and the lower limb, the identification of risk and why that is so important in foot screening, the services and pathways which are available, what to do if you're presented with a low, moderate, high and acute risk foot, and key messages to give to people living with diabetes in order to avoid foot complications. Now, I'm just going to mute my video, so hopefully this doesn't interfere with my signal, because I've got a bit of a poor internet signal. Now, within the National Annual Care Process recommendations, this talk will focus on foot examination and include examinations of the foot sensation and pulses with footwear checks and advice. To give some background information, 15% of people living with a diagnosis of diabetes will suffer with foot ulceration at some point during their lives. 5 to 7% of people will have current or previous foot ulceration at any one time, and 2% will experience at least one new foot ulceration per year. Foot complications are the most common cause of admission in those with a diagnosis of diabetes, with foot ulceration preceding up to 80% of amputations in people living with diabetes. After a first amputation, there's 23 times more likelihood for a further amputation compared to people living without a diagnosis of diabetes, and unhealed foot ulcerations are the biggest cost driver. Up to 10% of the NHS budget is spent on diabetes. And about 90% of this, 80% of this is spent on the complications of diabetes, up to 90% of which, when it comes to the foot and diabetes, is spent on foot ulcerations. And there's roughly about a 60% cost, which is in community podiatry and outpatient and primary care settings. As we can see, there is a huge amount which is spent on foot ulcerations and the secondary complications of the foot in diabetes. And so we really want to try to reduce this as much as possible. Currently, there are up to 184 amputations each week within the UK, which leads to over 9,500 amputations per year. And it's considered that up to 80% of these amputations are preventable. The likelihood that a person with diabetes will have a leg, foot, or toe amputation, as I mentioned before, is around 23 times more likely than that of a person living without a diagnosis of diabetes. In many cases, amputation occurs as a result of foot ulceration and infection, and we see that in up to 85% of cases. After a first foot ulceration, the 5-year mortality can be as high as 50%, which increases up to 70% after somebody suffers an amputation. It is considered, as Jayne's already mentioned, that up to 80% of amputations are preventable, and we want to try to work to reduce this. Within diabetes, there are both micro and macrovascular complications, which we need to be aware of. These can lead to secondary complications, which would include the 90% of amputation. As we see in the Diabetes UK's incredible publication, which is entitled Diabetes is Serious, there are up to 190 amputations per week due to diabetes, 770 strokes, 590 heart attacks, and 230 cases of heart failure cases, and that's per week. Now, too much glucose in the blood from diabetes can cause nerve damage, which is referred to as neuropathy. And we can also see poor blood flow, which is referred to as ischemia. These can lead to serious foot complications. Nerve damage occurs when there is damage to the nerves, which can stop sending signals, or they may send signals slowly or at the wrong times. Neuropathy can cause people with diabetes to lose feeling within their lower limbs, meaning that they may not feel pain, heat, or cold in their legs and feet. They may not feel a prominent seam inside their sock or an object which has fallen within their shoe, and this can cause a sore or a breakdown. People may not be able to feel if there's any pressure on their feet from poorly fitting footwear. Sores or breakdowns on the feet can become infected. And if the blood glucose is high, the extra glucose can feed an infection within this breakdown, and the infection can get worse. Nerve damage can also cause pain and lead to foot deformities or changes to how the muscles, in the muscles and bones and the shape of the feet. And this is because the damaged nerves cannot send messages to the foot muscles regarding movement, which can become very weak and imbalanced. Sensory neuropathy is the most common form of neuropathy which we see. It affects the nerves which carry messages from the skin and bones and muscles to the brain and can lead to a loss of feeling and a failure to sense pain or extreme temperatures. This can mean that there's a reduced ability of a person with diabetes to sense the potential harm which is being caused to their feet. For example, developing a blister or a minor burn or a rub and a breakdown within the shoes. These injuries can become infected and develop into an ulcer if appropriate treatment is not provided. Motor neuropathy affects the nerves which are responsible for initiating movement in the feet and legs, such as walking. The nerve damage can cause the foot shape to alter, such as clawing of the toes, high arches, and we can also see cases where there is foot drop, so there's an imbalance of the muscles which then happens. If there are any cases of foot deformity, we need to make sure that somebody's footwear is able to accommodate their feet. If the toes become clawed, or if we notice that there's a change in the shape of the forefoot or the midfoot or hindfoot, we need to ensure that there is a good accommodation of the feet. We want to make sure that there are no seams. And when looking at somebody's footwear, we need to make sure that they are the right length, width, depth and shape to accommodate the foot and any insoles which they may also have. We also need to give advice to individuals to always check inside the footwear to make sure that any foreign objects haven't then fallen in or that any insoles or anything that they have in their shoes haven't rolled up and caused, which could result in a problem due to high pressures. With autonomic neuropathy, there is damage to the nerves which affect the sweat glands, which reduces secretions and makes the feet very, very dry. Dry skin and fissuring can be noted, which can make the skin prone to cracking and also infection. It can also affect the circulation of the feet, leading to edema and swelling. Now, Professor Edmonds, in his presentation, will speak more about the sequelae of foot disease and diabetes. So I'll only briefly talk about the Charcot foot. But if somebody presents to you with a warm, puffy, swollen foot, which can be associated with pain, or if there's a change in the shape of the foot, then we need to act very fast. We need to act now, as Jayne says, to try and get the right treatment at the right time for these people. There can be microfractures, which could potentially lead to bony disruption and severe deformities. And this is often overlooked as symptoms can often be masked due to the existence of neuropathies which are present. In about 30% of people with Charcot's osteoarthropathy, there can be background complaints of pain or discomfort. But in order to try and prevent the risks of deformities, we need to try and get early diagnosis and prompt treatment. Now, in peripheral arterial disease, circulation may be affected by narrowing of the arteries, and this is referred to as ischemia. This can happen to all blood vessels within the body, but especially those supplying the lower limbs and the feet and ankles. Reduced blood flow seriously impedes the healing of any wounds or infections which may be present. Sometimes severe infections do not heal and tissue around a sore or a breakdown can die, and this is referred to as gangrene. So if you should ever notice somebody with an area of skin which has become black and malodorous, they need to be informed to contact their emergency foot team or accident emergency urgently. Dry and cracked skin is also something which we need to be aware of when we're performing any foot screening or examining anybody's feet. Dry and cracked skin can be caused by high blood glucose, nerve damage, or poor blood flow. We can also see hard skin building up in areas of pressure, which can be due to a change in the foot shape or poorly fitting footwear. Any pressure can cause a breakdown if it's not managed, and so we need to be able to ensure that somebody has the right care and orthotic intervention, whether that's insoles or accommodative footwear and insoles provided to them. We also need to provide the right advice with regard to care for the feet if there is dry and cracked skin present. Now, when it comes to performing a quality diabetes foot screening, it's important for the individual to know why they are there and why they're coming to see you. Somebody who's being examined will always need to remove their footwear, socks and tights in order to allow for a thorough foot examination to be conducted. I know it sounds strange to be able to say that. However, some work which was done by Diabetes UK some years ago did highlight the fact that a lot of patients were not being asked to remove their footwear and their socks when they were having a foot screening performed. It's important to ask any individuals if they've had any problems or ulcers with their feet in the past, and ask if they're on renal replacement therapy or dialysis. It's important to see if someone's able to reach their feet, and ask what their current foot care regimen is like. It's also a good idea to test somebody's eyesight. When examining the feet, it's important to check for breaks in the skin. We're looking for open wounds. We need to look for scarring, any fissures, any corns, any calluses, any structural deformities which are present. And if there are structural deformities present, are they flexible or are they fixed? And in your mind, then it's a question to if they need to be referred on to an orthotist like myself or a podiatrist in order to try and accommodate these and redistribute any pressures which may be occurring from that. You need to be able to observe if there's been any previous amputation to the lower limbs, and also conduct a sensation test using a 10-gram monofilament. We need to see if there's any signs of previous wounds, any discoloration. We need to see what the nails look like, palpate for foot pulses, ask if there's any pain, and it's always important to look at the footwear that someone's presenting with to see if it's appropriate in terms of if it's heavily worn, is there anything inside the shoe, and also if it's the right size, shape, length, and width for the individual. When conducting a vascular assessment, we need to look for discoloration on the apices of the toes and the borders of the feet. Take a history of pain which somebody may be feeling recently, especially on exertion, or if they're walking on the flat or on an incline. It's also important to ask someone for their smoking cessation and look for any results which may be available in their patient notes for lipid profiles and body mass index. We check for the dorsalis pedis pulse, and we also check for the posterior tibial pulse.
On the foot, there are two main pulses. The dorsalis pedis pulse is located on the top of the foot, running towards the big toe. It is important to note that this pulse is absent in around 10% of the population, and the location may vary slightly between individuals. The posterior tibial pulse is located just behind the medial malleolus at the level of the ankle joint. Place the first and second fingers together lightly on the patient's skin overlying the pulse site that you're examining, ensuring your thumb is kept away. You should feel a regular, light beating. If you cannot feel a pulse, try the next site and then return to this one afterwards and try again. In most instances, it is sufficient to record pulses as being either present or absent for a foot screening. If you are unable to feel either of the two pulses in the foot, then there is a need for an onward referral.
Moving on from doing the vascular assessment, it's important to do a neurological assessment. And with this, we need to take a verbal history of the individual to see if they're noticing any signs of any tingling, any burning, any numbness, or any banding feeling or any tension within the feet. You'd need to use a 10-gram monofilament in order to test for neuropathy. And also, as part of your examinations, look for the signs of callus, as callus can build up in the presence of neuropathy. The presence of callus, overweight-bearing areas of the foot, is a high risk factor of developing ulceration, which increases the risk by up to 77%. If you notice that there's any blood-stained callus and neuropathy, it's considered to be highly predictive of ulceration, with it reported as being present in up to 80% of reported cases after callus has been removed. When before you actually perform a neurological assessment, it's always useful just to just bounce the monofilament on the individual's forearm first, which is very sensitive, and then they know the sensation to expect in the feet. It's useful to ask the patient to close their eyes and not lead them into asking if they can feel the monofilament as it buckles under the foot. So you don't want to be saying, can you feel this? Can you feel this now? And how about now? You don't want to lead them. You just need to ask them to say yes whenever they can feel it.
When testing sensation in the feet with a 10-gram monofilament, a minimum of 3 sites should be tested, avoiding any areas of hard skin. If sensation is absent, recheck the area up to 3 times. If the patient cannot confirm the detection of the monofilament, they will be deemed at risk of developing a foot ulcer and onward referral is necessary. In order to ensure safe and effective use of your 10-gram monofilament, please use the following guidelines. When testing
monofilament should be held in position for up to 1 to 2 seconds and then slowly released over the next 1 to 2 seconds. If the individual can then confirm if they're able to feel the filament when it's introduced, then that will be a sign that they're able to have that sensation. Along with the foot screening, it's also important to check somebody's shoes. Like I say, see that they're in good condition, advise someone on replacement, and provide advice on finding the right footwear and when to test or check the fitting of footwear. Patients should be encouraged to change their socks, stockings, or tights every day. These should not have any bulky seams, and the tops of them should not be elasticated. These should also be of the correct size and shape of the feet and should not be too tight around the individual's foot or ankle. Socks or stockings should always be worn with footwear, and if someone has been prescribed with compression stockings, these should be worn as directed by the physician or clinician who has prescribed these and be reviewed regularly. Once you've performed your foot screening on an individual, it's important to ask yourself if there's a need for an onward referral and know who and how to refer on. There is a foot risk stratification and triage system, which will help people in determining what actions are needed. But if someone presents with low risk, they have a normal sensation, good pulses, which can be felt on both feet, and no signs of peripheral arterial disease. There'll be a history of no ulceration with no foot deformities and no visual impairments present. There can be the presence of mild hard skin, but there are no other risk factors. In this case, it's recommended for annual screening by a suitably trained healthcare professional with a self-management plan in place, and written and verbal information and education is provided with emergency contact details. For those of moderate risk, the definition of is that there's a loss of sensation or absent pulses or signs of peripheral arterial disease. There can be previous vascular surgery which has been performed, or foot deformity and callus, or significant visual impairments, and someone is unable to self-care. In these cases, it is recommended for regular assessment and treatment by a podiatrist with agreed and tailored management treatment plans by the podiatrist according to the individual's needs. Again, written and verbal education and information needs to be provided along with emergency contact details. For those of high risk, these are individuals with a previous ulceration or previous amputation or consolidated Charcot. They may be on renal replacement therapy or have absent pulses with neuropathy or callus with an identified risk factor. The recommendation is for agreed and tailored management plans and treatment pathways by a podiatrist who is experienced in complex diabetes foot problems, and again with written and verbal education and information provided. Now, if someone presents to you with an active foot problem, there may be a foot ulceration, signs of spreading infection, critical ischemia, or gangrene, as we mentioned before, or there could be Charcot's osteoarthropathy, or an unexplained hot, red, swollen foot, which may be with or without the presence of pain. Then it's important to get that rapid referral and act now. So we need to get someone directly into a multidisciplinary team. There's a new definition of someone being in remission, and this is someone who has had a previous active foot problem, which is then healed or consolidated. They then go back into the high risk factor, but they have that increased vulnerability for reactivation of the conditions again. NICE recommendations depend on the level of risk that an individual has. it's recommended that those who are at low risk have an annual foot screening, and this should occur more frequently if someone's at moderate risk, and more frequently again for those at high risk. There are patient education and information leaflets which are available. These have been nationally ratified across the UK. These can be downloaded from the Royal College of Podiatry's website. These have been developed to reduce the variation in information given to people with diabetes, as well as ensuring that the right information is available to the right person at the right time. On the Royal College of Podiatry's website, this information can be spoken out to the individual, as well as having different languages available as well. These leaflets are currently in the process of being updated, and I'm proud to say that in the new update, the Act Now policy is being implemented and included within these. The effectiveness of foot screening. So we see that foot ulceration can be predicted by effective screening and risk stratification. It isn't important who undertakes the process of diabetes foot screening, provided they have the following: that they've got adequate competency and training, that they have the right tools available, such as the 10-gram monofilament and access to the right information, and that they have the knowledge of the action required depending on the risk status of the person with diabetes whom they're seeing. An ability to provide the right information to the person at the right time is paramount. Good and effective foot screening in people with diabetes can have many positive results. The risk of the foot ulceration can be predicted by effective foot screening and stratification. Those who are accurately identified as low risk have up to 99.6% chance of remaining ulcer-free, and those accurately identified as being at high risk are 83 times more likely to ulcerate than those of the low risk group. It's important to remember that a foot screening on its own will not prevent amputations. It's a foot screening, it's not a diagnosis. And carrying out a foot screening, which results in the at-risk patients having treatment, management, and intervention, is very, very important. There's lots of tools which are available, which includes Frame for people who are wanting to do online training in order to be able to have competency in foot screening. And there's also more information, from the Diabetes UK website, which has got incredible links, as well as the Ideal team on the Act Now resources. Thank you very, very much for your time and listening to me today. Hopefully this has been interesting and has provided some information for you. Please feel free to drop any questions or any comments in the question boxes in the chat function available, or you can always get in touch with me directly if you need to. My name's Christian, and I thank you for your time. And it gives me great privilege now to pass over to my colleague, Professor Edmonds, who will talk to you more about the sequelae of the foot in diabetes.
Hi there, I'm just coming off mute. Are you okay there, Professor? You're still on mute if you're trying to talk to us. Again, still on mute, just in case. We have you now. I'll come off. Thank you very much for joining us.
Okay. We should.
You are sharing. It's not on presenter mode, but you are sharing, so we are able to see your screen. We can't see you at the moment. I don't know if you want to turn your camera on or not, if you're preserving your bandwidth.
My slide, can you see my slides?
We can see your slides. Sean, I just want to double check that Professor Edmonds is able, he's not got the no camera function still attached to his.
No, it's coming up for me that the camera should be fine. So not really sure what's going on there, I'm afraid.
Okay, thanks for checking.
Sorry, I've got my slides up now. Can you see my slides?
Yeah, we can see your slides. That's all good. Thank you. I'll leave it over to you.
Can you hear me, Louise?
We can hear you. You are breaking up slightly, so I think it's probably best to leave your your camera off, but we can hear you. If there are any further problems, I'll let you know.
Okay, fine. Well, thanks for the invitation. I'm going to talk about what you do if the person who develops a foot problem and consider how.
I'm sorry, I'm going to interrupt you because I'm afraid it isn't really great, and I've just had somebody type that they can't hear. Let me just see. Do you want to try again?
I've done the microphone here. Um, um,
Better. Hi, Professor.
Louise, can you hear me?
We can now. That's much clearer. Let's try that. Good luck.
Okay, so there are two main divisions of the diabetic foot. The neuropathic foot, where peripheral neuropathy obviously predominates and leads to numbness, and the ischemic foot, where there are blockages and narrowings in the arteries of the foot, reducing blood supply to the actual foot. There are various scenarios which we all have to recognize, and these are found in the neuropathic foot and the ischemic foot. It gets a little more complex here, but I'm going to show you pictures of this so you will be able to follow it. So in the neuropathic foot, we see ulcers. That's the neuropathic ulcerated foot. And also the Charcot foot is the second entity where there are bone and joint problems. Now, the ischemic foot has several presentations. I will show you the pictures in the next few slides, but essentially there's the foot where there's both neuropathy and ischemia. This is mild and moderate ischemia. The critically ischemic foot where the ischemia is getting worse, and then the acutely ischemic foot where there's a complete blockage. And we do see a lot of patients with ischemic feet who are on dialysis. So the neuroischemic and the critically ischemic foot have recently received the label of chronic limb-threatening ischemia. So these scenarios are vulnerable to the rapid destruction of the foot and the risk of amputation. And as Jayne has said, time is tissue. That basically is that there are several conditions which are time sensitive, and if one delays a diagnosis, tissue is destroyed. So I'm going to whiz you through the neuropathic foot, where is the prominent metatarsal head, and this will develop an ulcer if not protected, and then become infected and lead to infective necrosis. Then there is the Charcot foot, more rarely, but this becomes a hot swollen foot, as Christian has described, and if not protected, it will develop deformity and ulceration and infection and lead to infective necrosis. Then there is the neuroischemic foot, where an ulcer also develops on the side of the foot, and this can become infected and then lead to infective necrosis. Then we have the critically ischemic foot, where there is reduction in blood supply to the foot, and then this leads to tissue hypoxia, necrosis, and gangrene. There's the severely acutely ischemic foot, where there is a sudden blockage of the artery, and this leads to cyanosis, mottling, and then to eventually gangrene. And then finally, the renal ischemic foot, where small areas of necrosis initially develop, but these can spread to involve the digits and the forefoot. So these are the various scenarios, and they are called foot attacks, similar to heart attacks, and brain attacks, and strokes, because in the end, they all lead to tissue death, as you can see here at stage 5. So it's important to try and prevent this progression to tissue death. And there are two basic principles of care. The person who develops a problem needs rapid access and expert treatment. Jayne has talked about the importance of access, rapid open access to a focus of care, ideally a multidisciplinary foot team. And the second part, of course, is once the patient gets to that team, provision of expert coordinated care by the MDFT. Now, the MDFT can comprise various disciplines. I point out the cumulative list here of podiatrist, nurse, diabetologist, surgeon, radiologist, orthotist, microbiologist, and clinical psychologist. They're not all present at the same time, but they need to plug in at certain times in the multidisciplinary care of the foot. And it's important to have a focus, namely a diabetic foot clinic. It's a physical focus for HCPs and patients. Ideally, it's an admission center and a follow-up center after discharge. And essentially, it's a mission control center for hospital and community for the person with diabetes and a foot problem. All the problems should be referred here. The patients know where to go, and the focus then can concentrate on getting as good care as possible. But in the real world, not all hospitals have MDFTs, and when present, they meet only once, usually once a week in the office hours. So all of us who are on this call, who are linked in and have contact with diabetes people, all of us in primary as well as secondary care, have responsibility to know about and care for diabetes problems. So I want to just take you through these scenarios to explain how all of us can try and intervene early to prevent these progressions to necrosis. So we've looked at the neuropathic foot. Of course, we try protect the neuropathic foot and stop it developing an ulcer. Unfortunately, we can't prevent all ulcers, and they need then treatment, expert treatment, debridement, podiatric debridement, and a removal of the pressures on high pressure area with offloading, either with a cast, a total contact cast, or removing the cast, and hopefully one can get the ulcers healed. But we now come to the first limb-threatening situation, and that's infection. That 50% of ulcers become infected, and you can see here the cellulitis, which has developed here as a sign of infection, and that can lead to infective necrosis. And you can see the now paradigm can alert you to this. There will be a change, particularly in color. There will be increased temperature, there will be oozing, and there will be wound. And these people need antibiotics promptly, and that can come from the MDFT, community clinics, or GP practice. I'll point out 3 pitfalls with diabetes infection. They may not have pain, they may not have a fever, and they may not have a raised white cell count if a blood test is done. The infection may not produce this in diabetes. But it's important, wherever you see that patient, if you're in a care home or you're in a GP practice and you see that patient on a Friday, then antibiotics can be given on that Friday before the weekend. And this is an example where a patient presented to their district nurse and who noted a change in the color of the foot and an exudate oozing under the toenail. You can see that in more detail here. Was this ischemia? Was this infection? There was immediate referral to the MDFT, and ischemia was ruled out. Infection was diagnosed, antibiotics prescribed with resolution of the infection in 48 hours. Now, just looking back, if that antibiotic intervention had not occurred, that foot would have continued to change color and become gangrenous. And this is what happened to a foot similar to this. This was a toe with an ulcer. It did not receive antibiotics. This is a similar toe. It's not exactly the same toe, but again, a toe that did not receive, infected toe did not receive antibiotics. And this is diabetic gangrene. And one's got to understand that infection can also cause gangrene as well as reduction in blood supply. It's an indirect reduction in blood supply. This is a section of the artery in that toe, and you can see that there is a very small lumen where the blood can go through. And this was occluded or stenosed, as it were, by this clot here. This clot is all caused by infection, by bacteria. And one's got to intervene. If we'd had a time-lapse camera in that artery, you would have seen that clot gradually increasing, and it will block that artery. So infection's really important to treat. The second limb-threatening situation is a Charcot foot. Christian has mentioned this. It's a hot, swollen foot, often after minimal trauma. So the now will show you an accident, a change, temperature, and possibly new pain. After minimal trauma, it leads to rapid bone and joint disorganization unless it is offloaded. This was a 19-year-old girl who presented a long time ago to their casualty. Slipped on the ice in the winter. The X-ray of the ankle was then normal, and she was reassured. 6 weeks later, the ankle joint was destroyed. And this was a picture, dislocation of the ankle joint and ulceration, and she lost her leg. So if a Charcot joint is suspected, then the foot should be offloaded immediately, again, with a cast or a removable cast. But even if you haven't got that, just tell the person to get off their feet and rest their feet before they can get to specialist care. If they don't get offloading, two things can happen. Their deformity can develop and be totally inhibitive of walking and mobility. You see this deformity, or else, as I've showed you, it can develop deformity and infection and necrosis. Just going to the left-hand side, this foot was deformed. We set about reconstructing it with the team. Patient had arterial disease that needed a bypass. Then the patient had reconstruction with metalwork to straighten the foot. There was a bypass needed further down the foot, and then a long-term treatment to heal the wound, which could not be closed, and then a skin graft, and then total healing. But that process took a whole year. That was a whole year out of the patient's life. And the other sad thing is that this involves a lot of complex procedures. It's only available in a few centers, and it's difficult for patients to get. We get a lot of referrals at King's, and we have 70 patients on the waiting list waiting for surgery, elective surgery to repair that, and some will wait over a year. So it's really not acceptable. And then we have the Charcot foot, which develops a deformity, and we've got the infection scenario again. So just to point out, infection, change temperature, oozing wound, and you need the antibiotics either from the MDFT community clinics or GP practice. But I have a high index suspicion a red hot swollen foot should be considered a Charcot foot until proved otherwise. And finally, we go on to ischemia. Christian has talked about the foot pulses being absent as a measure of ischemia. We are now encouraged to measure toe pressure, and the level of less than 30 is indicative of critical ischemia. And this is to help you measure the Wi-Fi classification. I mentioned this. It's being carried out in some centres in the UK, but it's a score combining the wound, the infection, and the grading, ischemia grading. I won't go into a lot of details, but basically you grade the wound from no ulcer to extensive ulcer or gangrene. You grade the ischemia with a toe pressure or TCPO2 from above 60 to below 30, and you grade the foot infection from non-infected to severe infection and sepsis. Having done that, then what one can refer, if necessary, with a Wi-Fi classification score as information to the vascular department. But I'll quickly go through the various entities here because they bring up limb-threatening situations. This is the neuroischemic foot, which develops an ulcer. It should be accommodated with wide-fitting shoes, which these are obviously well used, and often it's very successful in reducing the ulceration. But again, 50% get infected, and you can see the cellulitis here, and then the infective necrosis. And again, antibiotics are needed from the various sources of MDFT community or GP practice. I come now to the two final limb-threatening situations. That's critical ischemia. Here, if you measure toe pressure, it's less than 30. But if you can't measure toe pressure, you really can make this diagnosis, I think, clinically. And it's a combination of rest pain at night, even though the patient has neuropathy. The pain is relieved by hanging the foot over the side of the bed. And what we call Berger's sign is positive. And you could do this anywhere, in the care home, in the GP practice, in a patient's home. If you elevate the foot, it becomes pale. You can see this area here. If you then put it dependent onto the floor, with gravity helping it, it becomes inflamed. Well, not inflamed, it becomes dilated. The capillaries are dilating as a last gasp effort to keep the skin intact. So you have a red foot on dependency, and that is classical critical ischemia. And the basic message is that patient will need more blood supply to that foot within 14 days. So you've got to refer that patient pretty quickly. And then there's finally the limb-threatening situation, acute ischemia, where there are the typical features of acute ischemia. This is where there's a sudden blockage of the blood going to the foot. And we notice this with the 6 Ps. Pain, present pallor, or cyanosis for mottling, as I've showed. Pulses, absent pulses. The foot is perishing cold, and because the blood supply to the nerves are going, you get pins and needles, paresthesia, and you get power loss. And that foot needs immediate revascularization. Just a note on the renal ischemic foot, there is usually severe ischemia, very distal leg and foot arterial disease, lots of calcified vessels. You see this necrosis, you see the calcified vessels. A balloon angioplasty improves the circulation, and you can get some of these healed. So that is the process of trying to intervene at stages 3 and 4 to stop stage 5 developing and the chase of gangrene. I should see the time going on now. I will quickly whiz through this. If we're not successful at this, and we patently aren't successful, as between 2017-18 and 2019-20, there were nearly 8,000 major amputations. Patients with a greater risk of amputations were males from the most deprived areas, supporting the aphorism that gangrene is a disease of the poor, aged over 65, and white ethnicity. We've had slightly more recent data up to 21, but similar results. There's a fivefold difference. There's a postcode lottery of the amputations. If you live in one area compared with another area, you could have 5 times chance of having an amputation. And how do we do compared with the rest of Europe? Well, these are two parts of the league table. The upper part show the increased number of amputations going to lower. In this league table, we're much better than the countries that you see here, but in this league table, we are not. And these countries, so in a Euro competition, we would not win the Euros. In fact, we wouldn't even get to the last 8. So what are we going to do? In the USA, there's the American Limb Preservation Society pushing back the clock, eliminating preventable amputations. And here we have the FD UK has formed a Zero All Preventable Amputations group to provide excellence in care of persons with foot problems. We've started to put out position statements. Jayne, with others, has written one on the missingness. That's people not getting to the clinic, not being there for a multitude of reasons. Louise has talked about delays in getting to specialist care, and we are in the last stages of preparing what the core services that a person with active foot problems should expect. So the take-home message is act now to highlight limb-threatening situations, and the 4 big ones are infection, Charcot foot, critical ischemia, and acute ischemia. If you want to know more, the annual meeting, the FDOK, is in November within the Wounds UK, and there's also you can look at the website. And as with Christian, I'm happy to be contacted through my email. So thank you very much for listening, and I'll stop sharing now.
Thank you to you, Professor Edmonds, and to everybody. I'm just trying to start my video multitask. It's not working well. Bear with me. Thank you all so much for sharing that. I'm very conscious we've got a lot of questions and not so much time, so I'm just going to start by working my way through them. So, Jayne, people are asking where they can order the Act Now cards from, and I think there were quite a few comments from people saying as well that the QR code that you shared, unfortunately, the link didn't work. Jayne, are you still with us? I'm trying to look to see if you are. If not, what I'll say to people is we will get in touch with Jayne and we will make sure that we find the correct link and hi Jayne, you're here, and share it. So I think what we'll do is we'll make sure we share that link. Do you know where people can order the cards from, Jayne?
So the cards you have to self-fund, but the checklist you can download from the Ideal website.
Okay, if it's possible to pop that website in the chat, or we'll try and share that when we send things round. What difference does it make to a patient on dialysis? Was a question that came through. I don't know who would like to take that. If anybody would, don't all jump at once.
Okay. So if someone has renal compromise, then quite often we see that there's a high proportion of people on dialysis who also have coexisting diagnosis of diabetes. With this, then they can have sensory neuropathy, but they also get uremic neuropathy. So they have a double whammy of neuropathies, which is affecting the lower limbs. Also, if there's a reduction in EGFR, then that's also increasing the risk factor due to metabolic changes as well. If you have someone who's then sitting or lying for hours at a time on a vinyl couch, that's a high point of pressure. But we do also see that, and so we need to make sure that that pressure is then offloaded and relieved as much as possible. But we do often see with our renal patients that there are subtle areas of breakdown which can happen. And that's not necessarily on a weight-bearing surface. It can be just at the peripheries or just between toes or just on the apices. And they tend to, we notice that those breakdowns happen very, very quickly. So probably a little bit more rapid than we'd see on someone who isn't on renal replacement therapy. And so having regular checks and reviews is paramount. There is information on the National Kidney Federation website on foot risk in dialysis patients. So do please feel free to look at that, and I can share that link in the chat just now.
Thank you, Christian. I'm going to try and rattle through them. I'm conscious of time. So somebody's asked, claw toes can be very prominent. What should we be advising people about this in terms of appropriate footwear for this type of deformity? This might be back to you, Christian, but I don't know if anyone else wants to jump in.
So it'd be trying to make sure that you've got footwear which is of an adequate depth and that the opening is good. It needs to be a wide and a low opening so that the foot can pass through. If you've got quite a narrow opening or if it's reduced, then trying to get the toes past that, you'd be causing trauma to the foot whilst doing that. And so you always recommend referral over to your orthotist. There's no such thing as a bad referral. If anything, then we can always use it, even if we're not providing treatment, we can use it to provide education and information to people. And so just being able to advise on the types of footwear which are available, make sure that it's the right length, width and depth. Often I hear in clinic, oh, but Christian, I've always been a size 8 or what have you, but things change over time. I used to be 7.5 pounds, but that was many moons ago. Things have changed, and so you don't always stay the same. I mean, I've got things in my wardrobe of a size that I was some time ago, so it's always good just to always check the size and the shape of the shoes that you're wearing. Between one manufacturer to another, sizes don't always they're not always the same, so always check.
Thank you. Fantastic. Next question is, what are the recommendations for vulnerable populations, for example, homeless, refugees, asylum seekers who cannot access a podiatrist? Thank you.
Just struggling to get off mute there. I think you'd have to look at your local guidelines and your local sort of protocols for access to podiatry, because they do vary across the country from ICB to ICB. I think there are some initiatives for people who are refugees, who are homeless. Some of the services do outreach from primary care, so you might be able to access that. You might find that there are some podiatrists who are allied to some of these outreach services, but I think you'd have to look at what was available locally. The Act Now cards and facility can be used with people who are homeless or who are refugees. The information is transferable, but I think you'd have to determine from your local provider what their entry criteria were.
Great, thanks, Jayne. Next question: are there any specific antibiotic guidelines for diabetic foot wounds?
NICE has got some guidelines. Can you hear me?
Yes. We can. Yes, we can hear you. You're all good.
Yeah, NICE has got some guidelines. The FDUK group is in fact looking at infection and will be producing guidelines. But there should be some local guidelines for every locality produced by the microbiology department, because there are some variations according to the geography as such of certain, say, resistance of certain bacteria. So you really should refer, I think, to the microbiology and infection disease department of your local district hospital.
Great, thank you. I think this might be another one for you. Are there any plans for Kings to do a podiatry masterclass again in the future?
Yes. Yes.
That's it.
Well, I refer you to the annual meeting of the FD UK. We're hoping to be doing one next year. I will say that there is one going to happen, but for various reasons, it's going to happen in Turkey in November, and that may not be uh, approachable for some of your people who are on this call at the moment. But we will certainly be having one in the next year.
Great, thank you. Another question, revascularization, Do we need to complete a Doppler and refer to vascular team, or is it just evidence of the 6 Ps?
Well, perhaps I'll take that. I think to make this clear, some units, vascular units, now are asking for this Wi-Fi score, which, if you can measure toe pressure, is fine. You can produce that, but I think the situation is changing, and if you diagnose clinically, particularly the 2 entities that I've described, the critical ischemia, or even more importantly, the acute ischemia, then you are perfectly justified in phoning up the local vascular unit, or the MDFT, because vascular surgeons go to the MDFT. I mean, for example, in King's, all the vascular combined appointments with diabetes happens in the foot clinic. So we have control of that, and I don't think people listening to this call should be timid or anxious in phoning up this vascular department unit. I mean, there used to be a concern, oh, I'll phone up the vascular reg. I'm not sure whether I'm going to have all the information. If you are sure that time is very important with critical ischemia and acute ischemia. So you've really got to be definite, and you don't necessarily need to have a toe pressure.
Great. Thank you all so much. Thanks for answering the questions. Thank you for everyone attending. I think I'm just going to start wrapping things up now because we've only got a few minutes to go. I want to thank you, Jayne, for explaining the acronym to us and why it's so effective and giving us all that feedback. Christian, I think it was really useful getting that step by step of how to do a foot exams and the vascular and neurological assessments. And Michael, for giving us all those different scenarios for all those photos, which were quite graphic, but so useful to see, and explaining the classifications. I think at the maximum was about 120 people we had join the call, which is great. And it's been really wonderful to be able to be a part of this with you. So thank you very much to all our speakers, and thank you for everyone attending.
Thank you, everyone.
Diabetes UK for the invite.
Thank you. All the best now. Thank you.